Well, good morning, good afternoon, and good evening, and good night to all the attendees, wherever you are, and welcome to our Madison Global Health Institute's Tuesday webinar series, where we will explore the importance of global health networks for pandemic preparedness with the Abbott Pandemic Defense Coalition. Thank you for joining us, and my name is Jorge Osorio, and I'm the director of the Global Health Institute. Our monthly Global Health webinar series features researchers and practitioners from the University of Wisconsin-Madison and around the world to highlight and examine the complexity of global health challenges and the many kinds of expertise needed to address them. As many of you know, our foundation at UW-Madison is rooted in the Wisconsin idea, a practice that takes knowledge and research out of the classrooms into real-world settings. And at GHI, we believe solutions to global health issues begin with investing in community-level conversations and a collaborative One Health focus in which human, animal, and plant health are interconnected. We aim to transform global health by fostering multidisciplinary and multisectoral conversations. As we know, the COVID-19 pandemic demonstrated how global health connects and affects all of us. The global pandemic shed light on the delicate and interconnected nature of global health security and the importance of sharing information to keep ecosystems healthy. The question is, what are we doing now to mitigate the next global health crisis or pandemic? And why is it important to invest in the health of communities thousands of miles away? Today's discussion will explore these questions with our esteemed panel. And before we jump in, a couple of quick housekeeping items. First, we are recording today's session, and the archive video will be available on our website at ghi.wisc.edu. And second, we are monitoring the chat, so please share your questions and comments for the panelists there. So with that, let's get started. Today, we begin by welcoming Mary Rodgers. Mary is an associate research fellow in Abbott's diagnostic business. In her role, she manages research from the Abbott Pandemic Defense Coalition, which is the first industry-led global scientific and public health partnership dedicated to the early detection and rapid response to future pandemic threats. As part of the coalition, over 20 sites around the world, including GHI's One Health centers and projects in Colombia, Mexico, Rwanda, and Sierra Leone, monitor circulating and emerging pathogens to help quickly detect outbreaks and then work together with health officials to minimize the spread. Mary also tracks the diversity of infectious diseases, including HIV, hepatitis, and SARS-CoV-2, to determine if new variants have impact on diagnostic testing. Mary received her PhD in biological and biomedical sciences from Harvard University. She completed her postdoctoral fellow at the University of Southern California and has authored more than 40 research papers and contributed thousands of viral genomes to public databases. Mary is also a proud Badger as she received her undergraduate degree from University of Wisconsin-Madison. Welcome, and thank you for joining us, Mary. We also welcome Juan Pablo Hernandez Ortiz, and Juan Pablo is the director of the GHI's One Health Center in Colombia at the Universidad Nacional de Colombia. Since establishment in 2018, the One Health Center in Colombia has been recognized as a center of excellence for the Global Virus Network, and since 2022, plays a key role in Abbott's Pandemic Defense Coalition. Juan Pablo oversees the One Health Center in Colombia, and with the team, he works in a BSL-2 lab where they run fever clinics and disease monitoring across Colombia. The current research covers SARS-CoV-2, arboviruses, influenza, blood parasites, solid tumor cancers, and other aspects of biomedical sciences. The One Health Genomic Lab is based on open access principles, and offers leading local capabilities in molecular biology, pathogen discovery, immunobiology, serology, and multiomics, with a very nice state-of-the-art sequencing platforms that can do from simple viruses to whole human genome. Juan Pablo has background in polymer physics, biophysics, complex fluids and has pioneered molecular engineering approaches to the design of platforms for personalized medicine. And during the COVID-19 pandemic, Juan Pablo was the co-founder of Vaxtera, a Colombian biotech company that develops vaccines and treatments for infectious diseases. Welcome and thank you for joining us, Juan Pablo. And finally, we welcome Sunil Solomon. Sunil is a professor of medicine and epidemiology in the Division of Infectious Diseases at Johns Hopkins University's School of Medicine. He's also the managing trustee for the YRGCARE Medical Educational and Research Foundation in Chennai, India. Currently, he co-directs the Johns Hopkins Center for Infectious Diseases in India. He completed his medical training at the Sri Ramachandra Medical University in Chennai, India, and received a Master's of Public Health and Doctorate in Epidemiology from Johns Hopkins University. His research is primarily focused on the epidemiology, clinical management, and access to services for HIV and viral hepatitis among vulnerable populations. He served as the deputy editor for the Journal of International AIDS Society and associate editor for drug and alcohol dependence. He's also a member of 2 technical resource groups for the National AIDS Control Organization in India. And they are People Who Inject Drugs, or PWID, and Antiretroviral Therapy, or ART. His team has established one of the first comprehensive clinics for the transgender community and people who inject drugs in India. He also serves as the co-chair of the Substance Use Scientific Committee of the HIV Prevention Trials Network. Previously, he was awarded $50 million from the United States President Emergency Plan for AIDS Relief to provide technical assistance to the National AIDS Program in India. He is also one of the only recipients of both the NIH Director's New Innovation Award and the Pioneer Award, the Avenir and the Avant-Garde Awards from the National Institute on Drug Abuse. Welcome and thank you for joining us, Sunil. So let's begin our conversation with you, Mary, to learn about the Abbott Pandemic Defense Coalition. Thank you, Mary.
Thank you, Jorge, for that kind introduction and for inviting me to speak with the community today about our work in the Abbott Pandemic Defense Coalition. So I would like to begin by giving some context about infectious disease research as a whole here at Abbott. And so I'll begin with the underlying purpose of a lot of the work that we do is because viruses constantly change, and we understand that viral diversity and all of those collective mutations have the potential to impact diagnostic and blood screening tests that we all rely on to be effective and tell us if someone is positive for any of the viral pathogens that we're monitoring. So that could be something like an antigen test or an antibody test in the serology category, or a molecular test where even a single mutation in the wrong position could potentially have an impact on a test. And so because something has to fundamentally be the same or conserved in every positive sample, we really need to know about all of those changes that are constantly happening in viruses that are circulating globally so that we can make sure that we are able to provide tests that work well. So if you look at the scope of the problem, I think we've all heard a lot about COVID variants over the years. We know that there's a lot of them circulating. There's a new one every day. And if we look at the viral diversity as a phylogenetic tree, so essentially the distance between each of the branches on this tree is proportional to the number of mutations that are underlying all of the different strains in a particular group. So we're looking here at one country in Brazil, all of the COVID variants. If we put all those COVID variants on the same scale as the variants that we see for HIV in the same country, in particular group N, which is the major group for HIV, we can see that the COVID variants are the size of a period at the end of a sentence compared to the amount of diversity that we see for HIV. And of course, this goes beyond just Brazil. This is a global issue. So Abbott has, over the years, been looking at viral diversity and also responding whenever there's infectious disease needs in the diagnostic space. So for examples in this timeline, going all the way back to the 60s, as new viruses like hepatitis B or hepatitis A or hepatitis C, and of course HIV, have emerged, Abbott has responded with first best-in-class tests to be able to detect those viruses and help keep our communities safer. So notably, as I mentioned, the HIV diversity led us to understand that we can't just put a test out and leave it out and forget about it. We have to continuously monitor how viruses are changing. And so that's how we came to launch the Global Viral Surveillance Program in 1994, which was dedicated to looking at the viral diversity for HIV through collaborations with our partners around the world. And so this program has grown and expanded to include hepatitis viruses and eventually SARS-CoV-2. And we've found some of the rarest strains of these viruses through the work that we're doing. We've been partnering with groups around the world to understand the viral pathogens in over 145,000 samples through this program. And we've published everything we've found along the way. So we have over 240 publications from our surveillance program looking at known pathogens. And that includes 50 countries that have been represented through that work on 6 continents. We've also layered in some public health studies over the years to understand the disease burden for some of these viruses through national serosurveys. And ultimately, we've also been looking at building tools to go beyond looking at known pathogens, start looking at novel pathogens, since we don't know what could be circulating that doesn't already have a diagnostic test. But of course, that's when we launched the Abbott Pandemic Defense Coalition in step with the COVID pandemic that emerged around the end of 2019 and beginning of 2020. And so this really was spurred by an already existing legacy of infectious disease research and an understanding that we're always going to need to stay a step ahead of viruses as they change and mutate and spread globally. So we were able to respond with a whole suite of solutions for the COVID pandemic, and our team started working on looking at SARS-CoV-2 early on in 2020 so that we could launch the first molecular test from Abbott on the M2000 in early March, just when we were starting to understand that this had spread globally and that we needed a lot of tests. And since then, we've delivered millions of tests in a variety of settings, including home tests that we continue to monitor today for their effectiveness for all of the variants that continue to emerge for SARS-CoV-2. And so ever since these tests have been launched, we've been checking and actually working with our partners through the Abbott Pandemic Defense Coalition, who have been some of the investigators who have identified many of the variants of concern, including Beta, Gamma, and Omicron, so that we can make sure our tests are working and detecting any strain regardless of where it is found. But we realize that the ongoing risk we face for the next pandemic only partially can be attributed to pathogens that we know about today. So these are things like outbreak viruses or variants of SARS-CoV-2 or other known pathogens that if a mutation occurs that changes their transmissibility or their disease pathogenesis, severity, that could cause a major problem in a global pandemic setting. But there's also another set of risk factors that is relatively underappreciated, and those are the unmet diagnostic needs that we face today. So something could potentially spread silently and go unnoticed, since a pretty significant proportion of a lot of illnesses that are caused by infectious diseases never get a definitive diagnosis to say what is truly causing that infection. So because we know that there's this gap in our diagnostics today, we need to be aware of what could be novel and emerging that we don't already know about in terms of sequences or diagnostic tests or vaccines or treatments. And so that's where the Abbott Pandemic Defense Coalition comes in. As Jorge mentioned, we're a first-of-our-kind global network that's dedicated to not just looking, but also responding to emerging viral threats and other pathogens. So there's 2 main goals of the program. The one is to identify and end current epidemics that we face today. So these are the viruses that we already live with, like COVID or HIV or hepatitis. The second part is to help prevent future pandemics. And we're doing this through our partnerships with all of our Pandemic Defense Coalition sites. Some that Jorge mentioned are part of the UW network as well as we work together. So total, we have 25 partners that are spaced around the world dedicated to this work. We're looking for ways that we can reduce the burden of existing infectious disease threats, as well as looking at ways that we can prevent future pandemics from happening. So through all of our partners, which are in positions around the world where we have a good geographic distribution and diversity of types of climates and risk factors that could lead to a potential pandemic, as well as strong technical capacity at each of these sites so that we can respond if we need to. So the way the program operates at each of these sites, and I'm delighted that you'll hear directly from Juan and Sunil about the work that they're doing following some of these workflows in Colombia and in India. But it starts with patients who are coming in sick to clinics. These are patients who are severely ill and meet the case definitions that we've defined through our program that will alert us to a potential risk for something novel that's emerging. So once a patient is enrolled in the program, we then start to try and understand what's making them sick. And this is done with diagnostic tests that exist today that we can use to rule out known pathogens. And you'll hear about how this has panned out in some of our sites where we see a pretty significant portion of people who are negative for all the known pathogens that we would test for that kind of sort of disease state or symptom profile. So we're left with the negatives who have the same kind of severe illness as people who were positive for other pathogens. And those negative cases go on to be sequenced. We, of course, sequence some of the known positives as well so we can understand their viral diversity. But when we're looking for a novel pathogen, we have to use a unique set of tools that we've developed over the years. And so we do an unbiased approach in our sequencing. So a metagenomic approach paired with a probe set that can enrich for pathogens that maybe we just didn't test for because they're very rare. So with that combined approach with sequencing, we then run all of the data through a new pipeline that has been also fine-tuned over the years so that we can rapidly identify whether there's something new in a sample that's never been seen before, or whether there's a pathogen that has a new variant or a pathogen that, like I said, maybe just wasn't tested for. So what's really important about the program is we don't stop there. When we find something new, a new variant or a new pathogen, we go on to the second part of this workflow at the bottom of the slide, beginning with the development of prototype tests. Those can be molecular, serologic, or rapid tests, so that we can then send them out to all of our sites to understand the disease burden and answer some of those really key public health questions that we have early on in an outbreak setting that we need to know, who's at highest risk, how far has something spread? And then we share that information with ministries of health in affected countries so that they can take appropriate measures using the information that we've generated so that they can protect their communities. And so to date, we've done a lot in the program across all of our sites. So we've now delivered over 600,000 tests. In addition to that, we've also included up almost 20,000 of these prototype tests that we've developed through the program. Overall, there's been almost 30,000 cases that have been enrolled, and this number grows daily. We've sequenced over half of them, and we've identified 23 new viruses that are under investigation. A lot of that work has already been described in 96 peer-reviewed publications, and so we can't go into all of those results today, but you'll hear some of the examples in the work in the talks that follow mine. We have identified 6 significant outbreaks that were reported to ministries of health in 3 countries, and we continue to investigate with those prototype tests that we've developed. In total, we have 48 to date. Training is a really key part of our program, and to date, we've trained over 90 and almost 100 future virus hunters, as we call them, many of them through the field epidemiology training program, where we're helping with that early step of the workflow. If I can go back, I'll just point out this case finding step is really key, because if we don't find the right cases, then we could be sequencing the wrong samples and getting a lot of the same results. We really are focused on that first step to make sure that we're finding the right cases. And that takes a really trained eye. And so the epidemiologists that we're training through this work are local and able to identify and support their communities in what the risks they face currently are. So if you'd like to hear more about our program, I know we can't cover all of it today. There are some QR codes here that range from a video series where we have 5-minute videos that give a deep dive into some of the sites that you'll hear about today. We also were featured in Time Magazine, and that article also has a video that you can learn more about the program. And then we also have our publications highlighted here, not all of them, but the really recent ones and the most important ones. And you can also find us links to PubMed from there. So with that, I'd just like to thank all of our partners. We recently had an on-site meeting with many who were able to join us here at Abbott for a really great discussion about the work that we're doing. And so I won't go through all the names, but I will highlight that Jorge and Sunil were in this photo and part of that discussion. And we were glad to have all of our groups working together. This is a really inspiring team to be working with. So with that, I'd like to hand it over to Juan to tell you more about the work in Colombia.
Thank you, Mary.
Thank you, Mary. That was so impressive. Thank you, Mary. Thank you so much. Go ahead, Juan
My
Pablo.
pleasure.
All right. Can you guys see my screen?
Yes, Juan Pablo.
Okay, thank you very much. So, Mary, thank you for your chat about the Abbott Pandemic Coalition, and actually prepare a lot of the slides that I am going to share with you guys. So it's going to be easier for me to just go deep in a couple of the results that we want to highlight today. So a little bit of context just on the One Health program in Colombia is a strategy that was born like almost 6 to 7 years ago between the University of Wisconsin and the Universidad Nacional, where we created the One Health program to start conducting research in the elements of One Health, like this view that the animal health and human health and environmental health has to be working together to be able to provide solutions to public health initiatives. And the first thing we did with the University of Wisconsin is to start leveraging the capacity building to be able to locate a laboratory in Colombia. And after 6 years, I'm very glad to share that we actually have a state-of-the-art facility where we are doing like 99% of the sampling and testing here in the site. This lab is and this program, of course, underlies the necessity of having interdisciplinary interaction between everybody. And that's where we actually locate that program at the university in the Faculty of Mines, which is our College of Engineering. We have units, pathogen discovery, human genomics, clinical epidemiology, and field studies that we try to keep always connected, like circulating and multiplying different projects. And the projects that I'm highlighting here, like the field clinics, like encephalitis and meningitis in pediatric children. Of course, the pathogen discovery that we do with Abbott and with all the members of the Abbott Pandemic Coalition, and then other things that we are evolving. Everything under a One Health principle, ethics, and of course gender equality, because we need to promote that as well. We are currently present in 6 different regions of Colombia. The Universidad Nacional has 9 different campuses, but we have presence with our own personnel in 6 different parts of Colombia, with PhD students, master students, and scientists that collect and do all these projects that I was talking before, and in the project that we are going to dig in sharing a couple of the results. More context about Colombia and about tropical regions is this slide that we love to share. It's a very scary slide. What I'm showing here is first the hotspots for re-emerging or for the emerging of novel diseases. And you can see that the tropical region is still highlighted, not only in South America, but also in Africa and Asia. I'm also highlighting the spots where zoonotic effects can highly appear, and there's a high prevalence or high probability of these events to appear. And again, India, Asia, like Africa and South America in the tropical regions are highlighted. Colombia is in the corner of South America with the presence of 2 oceans. So we are one of those countries that are called hyperdiverse, and the diversity in our birds and our flowers and our species is extremely beautiful and nice, but also brings the other things, that is, we are also highly diverse in pathogens. So we are we have a lot of climates and jungles and rivers and the oceans, and this creates the perfect scenario for pathogens to reemerge and to have, like, we have everything. We have malaria, dengue, Zika, chikungunya, everything in our country. So it's a very good, like, sentinel of what happens in other parts of the world. And this is concomitant with us human doing illegal migration, illegal mining, deforestation, and these human activities also affect how these diseases and how these threats of new emergence of pathogens can move very fast between countries and between continents. And one addition to that, Paris, is that we actually are in the center of migration, and a lot of the people, 90% of the people that migrate to the United States, actually crosses Colombia to the Darien Gap to go to the United States. So this mobility of humans and mobility of species create this perfect scenario for new diseases. In addition to that, and this is the last thing I'm going to say about context, is that I'm highlighting the regions with poor access to water, the regions where climate change affect the food security, the regions where the death rate of HIV and the cervical cancer deaths are higher. And all these regions are concomitant with these tropical regions where all these pathogens emerge. And this is just a diagram of the inequalities of the world and how the inequalities actually enhance many of the problems in public health. All right, so as Mary mentioned, we are very proudly a member of the Abbott Pandemic Defense Coalition, and I want to share two stories. One of them is in our pathogen discovery, what we do, and as Mary actually went in details, we go in 4 different sites in the country and we collect patients that have an undifferentiated fever for more than 8 days. And then what we do is we enroll them in the studies and we take samples and we bring the samples to the lab and we do like a protocol to try to detect what are the positive of these samples, whether if we find a virus, a bacteria, a parasite, or if we find like prevalence to a particular disease. And we do this and in a very disciplined way. Up to date, we have collected more than 8,000 samples, female and male. More females, not because they are more prevalent to diseases, because females are less scared to needles when we take the blood out. So they always say yes. The males, we need to really convince them to do that. And these are a couple of results that we have. We found dengue, malaria, Zika, so these diseases that are common and prevalent in our regions. But here in these plots, what I'm showing you from Leticia, Urabá, Villavicencio, and Casillas are only the positive samples. From those 8,000 samples, 4,200 are unknown. So they're negative to all these famous or popular diseases that circulate in our country. So then what we do is we dig into these samples to try to identify what are the diseases that are doing this as we follow the protocols that Mary presented. So let me share this story, or the Oropouche virus. And the Oropouche virus is something that you've been listening to the news because there's an outbreak in Brazil and in Peru. Well, this is a febrile disease that is transmitted by culicoids. Culex mosquitoes are all over the world, so it can be spread very easily between continents. And look at the symptoms: headache, muscle pain, joint pain, loss of appetite, and fever, which are the symptoms that are also shared with dengue and malaria and Zika and chikungunya. So symptoms that are very similar, and that's why sometimes the clinical diagnosis is for the popular disease, whether dengue or malaria, and not for the unknown disease. Well, in our fever clinics, we took samples that were not positive to anything. We did metagenomic sequencing, and we actually detected in 4 samples, in 4 patients, a full genome of Oropouche, and we did this like 3 years ago. With Abbott and with their expertises, they developed very fast assays to do molecular or serological detections of antibodies of the virus. We went back to our blood banks and we actually found a high prevalence of almost 30% of our samples were prevalent to Oropouche. So we actually detected and we did the sequence of the Oropouche, and we were able to characterize that this Colombian strain was like a combination from a previously introduced a strain of Oropouche in Colombia and from Ecuador. Now, following our field clinics in this year, we actually detected there was an outbreak of Oropouche in Leticia again. And these cases, we actually were able to analyze them and do the sequence. And what we found that first of all, there was a co-circulation between the previously characterized strain of Oropouche in Colombia and a new strain that came from Brazil. And Oropouche is a segmented virus. So not only there was an introduction from that virus that was in an outbreak in Brazil, but also there was a combination between the two strains that were circulating in Colombia. So this is what the Abbott Pandemic Coalition is detecting the circulation, characterizing the circulation, and now try to attend what are the clinical consequences that these diseases are circulating in our region. With this, something very similar with yellow fever. Everybody thinks yellow fever is a matter of the past. Well, it is not. We detected a circulation of a South American strain with several mutations in Colombia. And now it's very sad to share that currently we have an outbreak of yellow fever in a region in Colombia that has claimed 5 victims all over the year to today. And it's because these strains are strains that are very different from strains that were used to develop the vaccines that are administered normally in the rest of the world. Now, finally, my last minute, I want to share that the Abbott Pandemic Coalition and the interaction with the University of Wisconsin push us to go into different things and to push us into things that are very important in public health. And the first thing we did is that we need to do a whole human genome in South America. So we actually are finishing the alignment of the Colombian whole human genome, where we use short reads and long reads to have a very deep and profound coverage of the whole genome. And we're doing this because we are characterizing tumors, solid tumors, to be able to identify what are the mutations and what are the genes that are present in the tumors from our region. And this is a push. This is something that we're very proud, and we are actually getting the results from now as we speak. But it's like all the branches that the interaction between Wisconsin and Abbott create to do high impact projects in our regions. Finally, this goes also into CAR-T and CAR-NK. We have projects of viral circulation, climate change, climate variability, nutrition, migration, and more. And this is the team. We are a big team right now, but we are very proud. And now I think I can move to Sunil.
Oh, Pablo, that was very impressive. So, Sunil, if you don't mind, please tell us about your work at the YRGCARE Medical Educational and Research Foundation. Thank you.
Sure. Thanks again, Jorge, for the invitation. And we're going to switch gears a little bit. I think Mary talked about the APDC, which is not just about finding new pandemics and being prepared, but I think there are several ongoing pandemics that we probably should be thinking about how do we end this. Right? And the key, I believe, to ending most of these pandemics is diagnostics and getting it in the hands of the people who are living with these infections so they know whether it's an infection or non-communicable diseases. I think diagnostics really are the key to ending pandemics. These are my disclosures. Most of what I want to present is about India. So just to give you a sense of India, so we are the largest democracy in the world. We're 1.4 billion people. We have a very low HIV prevalence of only 0.2%, but unfortunately, but in India, because of sheer size, the 0.2% translates to 2.4 million people, making us the second largest number of people living with HIV anywhere in the world. And for those of you who are familiar with HIV programming, we have UNAIDS set these targets, the 95-95-95 targets, where they believe that 95% of people living with HIV should be aware of their status. So that's your first 95. The second 95 is at least 95% of those people who are aware of their status should be on antiretroviral therapy sustained or on treatment for HIV. And then the third 95 is 95% of those who are on continued treatment should be virologically suppressed. So that's our goal for 2030. We're about halfway there. They said it was 90 for 2020. Very few countries met that. And now we've moved to 95 for 2030. So if you can see in India, that the biggest gap, about 21%, is in the people who are not aware of their status. Once we find them, we're doing a pretty decent job of like getting them linked to antiretroviral therapy and getting people who are linked suppressed. And this is sort of the pattern happening in most parts of the world where we've found everyone who's easy to find. And we have to start thinking about approaches and strategies of getting diagnostics into the hands of people who are not traditionally using routinely available testing programs. So the standard testing approaches that are pretty much universal and like in all over the world, including the US, is like index testing or contact tracing, which all of you are familiar from SARS-CoV-2, where you would enumerate the contacts of the person who's infected. In the case, I mean, I'm using HIV as an example, but it could obviously like take this to any other infectious disease. And you would test everybody like for HIV, and for especially if you're working with people who inject drugs, and you would look at like their sexual partners, their injection partners, enumerate them, and then you would test all of them. And network-based testing is just an extension of that, where if one of that immediate network shows up as positive, then you would elicit their contacts and test them. And so it's almost like a snowballing approach where you could try and get to the entire population. The other approach that's very common in India and many parts of the world is community-based testing, where instead of people coming to a facility, you actually give outreach workers and peer health workers test kits, and they go into the communities to provide HIV testing. And this is very common, especially with key populations. When I say key populations, I'm talking about men who have sex with men, or people who inject drugs, or the trans community, or female sex workers who face several challenges trying to access care in healthcare settings. And the last thing is opt-out testing. I think this is something most people understand is when you show up so if you actually look at diagnostics, your biggest cost is getting someone to come into a facility, right? But when they're in the facility, providing testing is very easy. So they've done several of these approaches, especially in the US, in syringe service programs towards the hepatitis C elimination program in the US, where by routinely providing opt-out testing in syringe service programs in Miami, they were able to increase uptake of hepatitis C antibody testing from about 40% to 95%. It was almost universal, right? And then in India, it's standard practice in all these antenatal clinics. So most pregnant women who are pregnant who show up in the clinic get routinely screened for HIV infection, and most surgical patients it also happens. So I'm going to talk about what's happening with the pandemic right now, the HIV epidemic, especially in India. So I think the profiles of vulnerable populations have evolved. We've focused so much on diseases, we've forgotten that people's priorities don't necessarily align with our priorities of getting them diagnostics. And the last thing we're doing, this is like a project we're doing with the APDC, is like spatially targeted approaches, but bringing in a whole person-centric approach. So when I talk about populations have evolved, I think currently in India, most people are seeking partners online, whether it's WhatsApp or Grindr or Tinder or Planet Romeo, everything is happening online. And so this is part of a PEPFAR USAID program. So we decided to say, let's try and get at these people online because we don't know their risk. They don't know their risk. What's really happening here? So those of you familiar with India, we have a lot of business process outsourcing. So most times when you call people for an issue, you end up talking to someone in India. So we decided to capitalize upon that, and we hired people from the MSM and the trans community, trained them on HIV prevention messaging and text messaging. We built a website called safezindagi.in. And so these outreach workers would go, they're virtual, right? So they're not actually going into the field because they're working with all these clients in virtual spaces. And the way they do it is like they log on to like Grindr or Tinder or Planet Romeo and say, hey, I'm from this organization. I want to talk to you about HIV. Are you interested? And if people say yes, then the entire conversation moves to WhatsApp. And over WhatsApp, they're able to give people control of their own journey. And so we do the education first, and we ask them, do you want to be tested? And if people say, yes, I want to be tested, be like, okay, do you want to go to a public sector facility? Do you want to go to a private sector facility? Do you want to self-test? Like really putting control of your healthcare journey in your arms, right? So that's sort of what we've done here. And so we've built it in the entire continuum. And all this happens from Delhi and Hyderabad. We have 2 offices, but we've reached, I believe, 300 different cities across India, right? Just sitting in these 2 offices, because when you're virtual, you're pretty much everywhere. right? And they've also had to evolve because they've figured out like now there are these hidden groups on Facebook where you can go and log on and you get onto these WhatsApp groups. And on WhatsApp, they use the poll function and say, hey, how are you interested in PrEP? And anyone who says yes to that, they switch to a direct messaging platform and start working with them and getting them access to PrEP. So we've been running this program. It's more like, I would say, like a semi-pilot testing phase. It's been running for about 3 years. We test about 1,000 people every quarter. And we have registered about 33,000 people, provided testing for about 26,000 people. So the orange are people who are actually going to a physical facility. The green are people whom we are sending tests to them, right? And it's a little different between the two groups because the ones where we are sending tests tend to be more rural because they don't want to go to a facility because they don't want to be judged for whatever behaviors they have. And you can see our positivity screening is about 1,500 out of the 26,000 people we've tested. So it's about 7-8%. And for those of you who remember, the general population prevalence was 0.2%, right? So we were tapping into a population that's almost 35 times higher prevalence than the general population. And what was really striking about this was 70% of the people who had never been, who were HIV, who were diagnosed newly with HIV, had never been screened for HIV before, right? So we were really tapping into this population that was not accessing general programming, but we're definitely interested. We're doing a decent job of like getting them on antiretroviral therapy. We got about 1,000 people on antiretroviral therapy through this whole program. The other thing I want to talk about are the trans clinics that we established. And so the trans community in India also face a disproportionate burden of HIV infections, about 5% of the, based on surveillance estimates in India. So we established what we call the Mitra clinics. This is again part of the PEPFAR funded program. And what we really did was we wanted it to be led by the community. So the entire staffing was the clinic was either trans men, trans women. I mean, a couple of gay men who were also helping with the whole, cisgender men who were also helping with the program. And when we did our initial pilot work, because it's PEPFAR funded, we had to talk about HIV and say, hey, what do you like about HIV? What services do you want? The one theme that clearly emerged from the whole thing was HIV is good, but we don't really care about HIV. We want to have skin whitening treatment. We want to have laser hair removal. We want to have gender affirming care. So those were their priorities. So we essentially had to put a laser hair removal machine inside the clinic. And that was the draw. So most people started coming into this facility to use the laser hair removal services and the cosmetology services, get B12 injections. So those were the reasons people were coming in, or to come and get their transgender identity card. Because navigating government systems, and those of you who tried doing it even in the US, is challenging. So if you're looking at people who are not computer savvy, it really does become challenging. So we have people who sit here with computers who help them navigate the system and get things done. And so we've seen about 5,000 clients over the past, since 2021. So it's about 3.5 years across these. So we have 3 clinics across India, and in Pune, Thane, and in Hyderabad. The photo I have there is from Hyderabad. You can see like we do provide HIV services, but it's wrapped around with other services, including mental health, gender affirming care, social support, legal services, because we really have to start shifting towards that whole person-centric approach, because what population priorities are very different from what we think our priorities are. Our priority is to get them tested for HIV, but their priority is gender affirming care. So we need to figure out how do you marry those two different approaches together. And again, we tapped into a population with high HIV prevalence. It's about twice the national estimate among transgender populations. About 3.5 is the the surveillance estimate for the trans community. We're finding about 5-6% of our clients are living with HIV. We did a similar project. This again is in partnership with the Abbott Pandemic Defense Coalition, or APDC. So Aizawl is a city in northeastern India, in the state of Mizoram. So they have the highest general population prevalence of HIV in India. It's about 1.4%. So again, when we went and talked to the kids about young adults, I would say, like in that 17 to 23, 24 age group, what do you want? How do we get people tested? Their whole thing was, we want Wi-Fi. That was the only thing they wanted. And so we established this facility and we gave them high-speed Wi-Fi, put a lot of games, like music, bands and karaoke machines. And so it basically became a place where these kids would show up after school to sit and scroll on Instagram or YouTube or whatever free of charge. Right? So, but when they were there, we started offering them like screening for HIV, for hepatitis B, for hepatitis C, a lot of counseling, including substance use counseling, group counseling, and a lot of referrals, because teen pregnancy is pretty common in this population. So there's a lot of linkage to obstetrics and gynecology is like one of the big referral services that we run here. So here this has again been running for about 2 years. We registered about 2,600, 2,700 clients. HIV prevalence is 3% reactive. It's not about, again, everything is voluntary. We're not forcing people to do all the tests. But again, 3% in a general population of young adults is about 15 times the national average, right? So again, we're tapping into things and into populations who are otherwise being missed. And for many of these populations, it's not HIV that's bringing them in. It's something else. And so that, again, I think that's something we have been working with Abbott on quite a bit. So the last thing I want to talk about is like this one project we've been doing with Abbott, which has a long history. So when we started off doing our work in India, we noticed in the city of Delhi, that big circle on the right was HIV incidence of an 18.5, right? Which really is extremely high in this day and age where you have effective PrEP, you have antiretroviral therapy. Why is incidence so high? So to try to understand that, we actually built a longitudinal cohort to try to understand what was driving transmission and looking at the networks and people whom you inject with in different ways. And just to give you a very quick tutorial to network. So you have something called an egocentric network, which is the very basic network, which is you and your immediate contacts are the people whom you inject with. If you go a little bit beyond and you start enumerating the contacts of your immediate contacts, that becomes a sociometric network. And then if you start throwing in spaces, then it becomes a spatial network. So for example, let me see if I can get my cursor on the screen. I don't know, but there are a couple of people here who are connected. I'm trying to see if I can find my cursor. That's fine. Anyways, there are a couple of people who are connected to each other because of the common space they inject in, but not necessarily because they inject with people together. Right? And the last thing is just expanding that even further. And bringing in both space and people, which is a socio-spatial network where you incorporate ties between individuals with each other, but also with spaces. And just to explain why all this is important, I'll walk you through what we did in New Delhi and what we did. So we recruited all these networks and we kept the recruitment going, but we also captured all the information on spaces where people injected so we could get as much information as we could about different network structures. We recruited about 2,500 people. And about 75% of the coupons were returned. The striking thing was that HIV prevalence at baseline was 37%. Antibody prevalence for hepatitis C was 65%. We saw a lot of clustering of infections. You can see for both HIV and for hep C, those big red spots in the middle explains a lot of clustering. Right? So you can look at it in a different way. And this has been really useful in driving field-based approaches for both testing and treatment and PrEP. And the one thing I do want to point out is we did see the routine factors that were associated with HIV incidents, but I think what was interesting here was this one venue number 40, out of all the 185 venues we had, accounted for almost 4 times higher likelihood of HIV acquisition than any other venue. And just to give you an example of what this network looks like, so all these purple spots are different places where people inject. And I'm going to let the network grow over time. So each of these little circles you see on the screen is one person, right? And you can see over time, the network just expands and starts growing across New Delhi. All the red circles that are showing up with the red lines are people who are newly picking up HIV infection. The pink are the people who have prevalent HIV infections, the people who can potentially transmit infections to each other. So that venue number 40 that I talked about is that venue right in the middle. And that one venue accounted for 71% of new incident infections, which means like all these different new red circles, 71% of the red circles were directly connected to that one particular venue. And as you move further and further away from the venue, your risk of HIV acquisition reduced. So I actually went to the venue, and this is where I think the whole role of APDC comes in. So I'd gone to this venue with Gavin Clarity, who's like the head of the APDC, and I said, when we went there, what we saw was this blue shed, but when we walked around the blue shed, it was just lines of people who were homeless, living on the sides of the streets, a lot of them injecting. And I looked at Gavin, and I said, Gavin, we have a blue shed here. Can we turn this into something that we could provide testing and other services for these individuals? And he said, what kind of services? And so we asked them, like, why aren't you being screened for HIV? And the response we got from them was, we don't know where our next meal is coming from or where we're going to sleep. So why would we care about HIV testing? And so I said, Gavin, we need to put showers, we need to put toilets, we need to get them food, and we had to figure out, does that improve access to diagnostic services? So that's essentially what we did. We started something called the Blue Shed Project, or the Blue Shed Model, where we married diagnostics and medical care with harm reduction, but also with social support. We built toilets, give people haircuts, food packets, blankets, sweaters, and we also have like mental health services that we provide. And these are just pictures of what the facility looks like. But I just want to show you that in about a year, we've registered a little over 1,000 clients. 875 have been screened for HIV, but the prevalence is 50%. Like almost half the people walking in are being diagnosed with HIV. Similarly, for hepatitis C and hepatitis B, extremely high numbers. A lot of them are referred to opioids or medication for opioid use disorder, sit-in service programs. But I think the most heartening thing was just providing access to like showers, toilets, and food packets. And the one thing we learned from this whole project now, from working and talking to these, I'm actually in Delhi, and we were in this facility in the morning. And again, it's just remarkable how many of them tell you, I have come here to use the shower or the food packets. And because I'm here for that, I figured, okay, I'm here, might as well get screened for HIV, right? So it really does show you that going forward, we really need to think about, start including the person in the disease and try not to keep them separate, because we need to figure out what people's priorities are and integrate diagnostics and care into that, because that's the only way we probably will end up ending existing pandemics. But even if we find a new pandemic, it's getting the tests in the hands of the people who need them. So I will end there, and thank you again for the invitation.
Well, thank you so much, Sunil. What an incredible presentation and incredible work that you are doing with the community in India. So we'll open the floor for questions. Please remember to put your questions in the chat. We have about 8 minutes left. So if you can, please go ahead and put your questions. There are a couple of questions in the chat, one question is that if for whoever wants to answer it, maybe Mary, you can take a start here. What's the best practices to standardize the recording of diagnostic testing data? Okay. What can we do from there?
That's a great question, because it is really hard in a lot of different countries with different clinics and different physicians, all trying to look at the same information in different languages and with different objectives for that particular visit with a patient. So it is really hard to standardize. And the approach that we're taking in the APDC is to have a case reporting form. So essentially, the same questions are asked at every visit in every one of the sites that we're working with. And it's a living document. We're learning as we go about what we need to change. And so you can never really start with something and consider it finished. You have to always kind of grow and change what those questions should be as you start to analyze the data on the back end. So I know that we have, Sunil and Juan, who have been working with this approach as well. And I know that there's different complications in different areas. So I don't know if they want to add to that.
Mm-hmm. Any comments from Pablo or Sunil?
Well, so I'm just going to add something to Mary, and I think the key is to do standard procedures. I mean, what we've been very successful is that the way we enroll the patient, the custody of the sample, the way that we ship the sample to the lab, the way we process the lab. Now, without actually 90% of our processes are automatized. So standardized helps to put a baseline on the diagnostics. Doesn't matter if we're looking for different things, or the doctor have a particular questions. Once we are able to communicate and to do a diaspora of a baseline procedures to manipulate the samples in Colombia, in Sierra Leone, in Rwanda, in India, then we are talking the same language, and actually that helps to improve the diagnostics as we move along.
Thank you, Juan Pablo. Sunil, you have any comments on that?
No, Mary and Juan Pablo summarize everything.
Yeah,
Yeah.
so there might be a question for you about what you have incredible managed community engagement. You have done incredible work with community engagement. If you can tell us, for other folks that are doing some similar work, the lessons that you have learned with community and government engagement, because you also have to have the blessing of the government to do your work.
Oh no, 100%. I think both are extremely critical. And we have engaged government and community even from the time we come up with the idea, because you need ownership from the government and the community. And because the only way you will solve a problem is if the government wants to do it. Now, you could probably do like one site or two sites or three sites. And so, but if you want to take it to scale, there has to be government involvement. And for HIV, we've done a very good job with the community who can advocate and push for things, which we haven't done with other infectious diseases, right? And so we've been involved with the communities right from the beginning, from the startup, to ask them like what services. And I think the biggest lesson I've learned is the best things and the best interventions you will ever design comes from talking to communities and not sitting in your offices and reading any JM. It is a highly, highly impact factor, but doesn't have the kind of impact at the population level that you want to have. So talk to the people whom you really want to help. And the only thing I'll say to the whole data thing, the question before, because I said about scale, is APDC is one network, but we need standardized data across every network. And there has to be data transparency, which doesn't exist. Because unless you have data transparency and you know what the flaws are, we won't be able to correlate our data with like other people who are doing similar work. And I think that's something that's very critical with pandemic preparedness.
Thank you, Sunil. I do have a question for Mary. As you have developed this network and deploy new tests, you are doing this for new diseases and different locations around the world. What are the major lessons you have learned as you develop a new test in terms of the technical components, but also regulatory and even politics that are involved in doing this work?
Thanks for the question, Jorge. It is, I made it sound a little easy, but it's not when you get down to it. So for one thing, we often have very limiting sample volume to really make sure a test is working that's in a prototype stage. So that's from the technical side, I'd say one of the major challenges. But having even just one sample and one sequence is enough to get started. And then once we send it out, we learn if there's more cases, if the test is working well. But sending it out is always a challenge, because these are research use only tests that are prototypes. And a lot of the times shipping internationally can take a long time depending on the regulatory bodies that issue permits. And I'm sure anyone who's worked globally before has experienced this. Sometimes shipping something is harder than making the material in the first place. And so we are working together with our partners to understand the processes better. And we've actually been able to deliver almost 20,000 tests to all of our sites, which is a lot when you think of all the permits and shipping requirements that exist. So we're working through it, but it's definitely a challenge.
Yes, that's quite amazing. Maybe just to finish, Juan Pablo, you can comment how this APDC changed the work you do in Colombia before and after APDC. What is your feeling about how things have changed?
Oh, well, Jorge, is completely different. I mean, the evolution of the One Health program in Colombia, thanks to the more than the funding or the pushing or the equipment, is the interaction with everybody else in the world, and to push our limits and to always try to evolve. And we, at the beginning, we were one side and we were very humble and timid and small, and then we are connecting, and as we connect, we grow. And then especially following protocols. This is very important. GLP standards for the lab, like the way we manage the data, the way we do the bioinformatics, everything exponentially improves quality. And exponentially, as Sunil was mentioning, at the end of it, we want to impact the communities, right? We want to impact the regions. Those regions that are far away, that have no capacity to diagnose all stuff. At the end, we end up affecting these people, that we can tell them you have malaria, or you have dengue, or you have moropuche, which for a person with a fever it changed life.
Great. So that's all the time that we have today. I want to please join me to thank Mary, Juan Pablo, and Sunil for such a very enjoyable and great discussion, a great webinar. And also I want to thank you all for joining the webinar. And then also like to invite you for our next webinar on December 11. That will be at the same time. It will be about global networks. So, so thank you so much for joining, and have a great rest of the day. Thank you, everyone.